thrilled to be joined today by Dr. Ephrat Levy-Lahad from the Shar Zedek Medical Center in Jerusalem, Israel. We've asked Dr. Levy-Lahad to join us today to talk to us about inherited breast cancer, particularly breast cancers that are caused by inherited mutations in the BRCA genes. Dr. Levy-Lahad, thank you so much for joining us today and taking time out of your busy day. I'd like to begin by asking you to introduce yourself to our audience and tell us a little bit about the research that you're doing in understanding hereditary breast cancer, especially for women in Israel.
Thank you, Margaret, for inviting me. I'm a medical geneticist. I was originally an internist, and my interest in cancer genetics began in the mid-90s. I met Mary Claire King, who was also a BCRF grantee and probably the mother of inherited breast cancer. And in Israel, there is a particular high frequency of women with inherited mutations in these genes because about half of the population is Ashkenazi Jewish, and Ashkenazi Jews have a particularly high rate of mutations in this gene. So really this offered a paradigm for studying hereditary breast cancer, which we've been able to do thanks to the BCRF, and start doing sort of large population studies when these weren't yet possible in other populations.
So tell us a little bit about the rate of incidence of inheriting a BRCA mutation among the Ashkenazi Jewish population compared to non-Ashkenazi or the general population, and do we understand what's driving these differences?
So in Ashkenazi Jews, about 1 in 40, either men or women, carry one of 3 common mutations. If you look at the rate in other populations, the original estimates were substantially lower, but as genetic testing has become more feasible, I think the estimates seem to be around 1 in 160 or 1 in 200, so about 4 to 5 times lower in other populations. So it's a difference, but not a difference of entire magnitude. The reason for the particularly high frequency in Ashkenazi Jews has to do with the genetic history, really. And as we know, there are a number of diseases that are more common in the Ashkenazi populations that have nothing to do with breast cancer, diseases like Tay-Sachs, for example. So it has to do with the Ashkenazi Jews being sort of like a more limited tribe of individuals with specific mutations. And that's also been true of some other countries. For example, in Iceland, there is also a founder mutation in BRCA2. So really, I would say the high frequency is a matter of genetic history, and it matters for the kinds of studies you can do, but it doesn't matter for the generalizability of the results or its applications to other populations.
So your work has focused a lot on genetic testing to identify people at risk, and of course this is the only way that a man or a woman would know whether or not they are a carrier of a BRCA mutation. Why is that particularly important, for instance, before a cancer diagnosis?
So I think that if you look at inherited breast cancer, you can view it in the sense of, fear of having the disease, which I think is a very common and understandable way to look at it. But I think it's also very empowering to know if you're at high risk, because then you can really do something about it before you ever develop the disease. So the focus has really been on risk reduction surgeries so far, although we hope that in the future there will also be medications and other ways to reduce risk or to prevent cancer in people at high risk. Now, obviously, if you don't know about it before you get the disease, you can't prevent it. And the focus, as I said, has been on surgeries. Our work has recently also shown that even if women know in advance that they're carriers, even if they don't choose to have a double mastectomy, which is still the most effective way of reducing breast cancer risk, they still have very tangible benefits. We showed that women with breast cancer who knew ahead of time they were carriers had better survival than women who found out only after they were diagnosed with cancer. They were diagnosed at earlier stages. They required less chemotherapy, And so it's really life-saving to know ahead of time that you have a mutation. Also, in the BCRF, we're obviously focused on breast cancer, but there's also very high risk for ovarian cancer, which is very hard to detect. And we know that most of the women who find out they're at high risk can also have their ovaries and fallopian tubes removed, and that really reduces the risk of ovarian cancer, and that's also very important.
Mm-hmm. And so genetic testing, the guidelines around genetic screening are really determined by a variety of risk factors, the most prominent one being family history, in terms of identifying people who should be screened, who are considered, significantly at high risk. But your research has shown that family history may not be a really fair predictor of whether or not someone could potentially be a carrier. Could you tell us a little bit more about that work?
So we did a very large population study in Israel where we actually we tested over 8,000 men in order to identify families with BRCA mutations that weren't biased based on their family history. So we actually identified the families by testing healthy men and then finding out among those men who were carriers what was the occurrence of disease or history in their families. And what we found out, and has since been found repeatedly by other researchers, is that about half of women who are carriers, in fact, do not have significant family history. And why would this happen? So theoretically, you could say, well, maybe the risk is not as high as we thought it was, but we actually looked at it and we see that the risk is still high. But the reason that people don't have family history has to do with both history and biology. So the history part of it is your family might be small, or there might be many men in the family, so there aren't that many women who are carriers, or you might have what we call Mendelian luck, just meaning we know that even within a family with BRCA mutations, about half of relatives are going to have the mutation and half are not. And if those half just happen to be men, for example, then you're just not going to see cancer. Or if in a particular family, if the ratio is a little less than half, so less than half of relatives are even carriers, you're going to see less cancer. The biology part of it is we know that the same environmental factors that increase risk for breast cancer in the general populations, having earlier menstruation, having children at older ages, less breastfeeding, all of that also acts upon carriers. So we know that carriers born in previous generations were at less risk than carriers who are young women today. And so you might have less family history because of the effect of these non-genetic factors, that there's less history of cancer in the previous generation. So all of that comes together, and about half of carriers actually do not have family history. And that's really what drove the whole idea of thinking about population testing, because I'm a clinician. Every time, in clinic, I see a young woman with breast cancer and I find out she's a carrier, and I think, oh my gosh, we should have known this before she ever got cancer. This is just a missed opportunity for prevention. And that's really what got us thinking, because about half of these women just don't have a family history and would not have been tested.
Mm-hmm. So, I mean, what do you think what do you think the future is for population screening, and how would you envision that?
I think that in the not too far future, all women and all people are going to be tested for their inherited cancer risk. There are some issues that can be addressed in places like Israel, where we've done our studies, and that are more complex in other societies. But that's one of the reasons to do our studies, is because we can then figure out what's necessary and what's a possible way to do it. So one thing to think about is you have to make sure that the mutations you're identifying, or the genetic variants you're identifying, are really meaningful. And that's easy to do in the Ashkenazi population, because we have 3 common mutations that we know for sure are pathogenic or disease causing. If you start doing more generalized screening, this issue becomes more complex, because there are variants that we still don't understand, what we call VUSs, or variants of unknown significance. And then you run into the situation where you test a woman and you find out she has something and you're not sure about whether it's pathogenic or not. I actually think that can be circumvented by just making the decision that for screening, we are going to ignore those variants of unknown significance and at least focus on the ones that we are sure are pathogenic, but that's obviously going to evolve. The other thing is you want to make sure you're able to offer the kind of screening that's required for women at high risk after they become identified. So if you have a lot of barriers for the kind of surveillance you need after you find out you're a carrier, then you haven't really done much good. In the study I described earlier, where we looked at the women who knew ahead of time whether or not they were carriers, what really made the difference in terms of early diagnosis was the fact that they underwent breast MRIs. And that's a relatively expensive surveillance procedure. So if breast MRIs are not available, then you're not going to be gaining as much benefit if you know ahead of time you're a carrier, unless you choose to have risk reduction surgery. The other component, so there are components to do with the genetic test itself. There's components to do with surveillance you can offer women after they find out they're at high risk. And I also think it's a new paradigm in terms of how we deliver genetic testing, because traditionally we've said that before you have a genetic test of this type, you should receive counseling before testing and then decide whether to get tested and then get counseling after you get tested. And this is not really feasible, and I don't think actually really necessary if you're doing it at a very large scale. And we've actually done studies to show that you can give much more minimal information ahead of time and then really focus your genetic counseling time and efforts on the women who you find out are at high risk. But it's really all of these pieces have to come together for this to be possible. And it's obviously simpler in the Ashkenazi population, but I think, like I said, in the not too distant future, I think it's going to be available to everybody.
So the work that you're doing in this very special population could really inform how we move forward in public health in general for genetic screening of high-risk individuals. Before I leave you, what do you think is the most important message to our listeners from this conversation?
I think there's a big focus today on what we call precision medicine, where once you become affected with cancer, the genetic makeup of your tumor and your own genetic makeup informs treatment. And what I would like our listeners to go home with is the idea of precision prevention. And I think that's what knowing inherited risk is really about, because if you know about your inherited risk while you're still healthy, hopefully, if you have precision prevention, you're not going to need precision medicine because you will not have developed your cancer in the first place. And my hope is that all of the listeners, especially the ones who think they might be at high risk, will realize the promise of knowing their genetic risk ahead of time.